Hi, everyone. Welcome to the 2024 Alamo Advocate Program from the Alamo Breast Cancer Foundation. I'm here today with Dr. Laura Esserman. My name is Jonathan Colemere. I'm the Executive Director of the Alamo Breast Cancer Foundation, and we're going to talk today about the Wisdom Study. Dr. Esserman, thank you for joining us.
Well, thank you for having me, Jonathan.
Great. So why don't you tell us a little bit about what led you to want to create the Wisdom Study? What was lacking in personalized medicine that led you to want to create this program or this study?
Well, Jonathan, I think this comes from decades of clinical practice and clinical research that, the entire field of breast cancer is moving towards this idea of better understanding the biology of each tumor, everybody's tumors, so that we could tailor treatment accordingly. And really, so much of our progress in treatment and a decrease in mortality has come from really understanding who needs what treatment and how different these cancers are. As I came to understand that certain cancers grow quickly, and also their risk is the risk of recurrence, that period is shorter. And then there's a number of people who have these slower growing, seemingly more indolent cancers with a sort of a long tail of recurrence that, it seems like these are very different cancers. And then it occurred to me, like, why are we screening everybody as if they were at risk for the same cancer or even had the same risk factors? It just didn't make any sense to me. And, there's a lot, there's, screening, there's a burden of screening, right? There's, if you screen every year for 10 years, you have 50% chance of being called back. And, half of those people wind up getting biopsies, and it's extremely anxiety provoking. And that's a burden of screening as well. I've watched the emergence of ductal carcinoma in situ, a so-called precancer that we treat as if it were stage 1 cancer. And these are, when people hear the word cancer, they think, oh my God, that's it. I have high risk. I have to have a bilateral mastectomy. And so on one hand, we're doing too much and probably overreacting to things that, don't need that same kind of treatment. And then on the other hand, it's been, almost 30 years since we've known about big risk factors like BRCA1, BRCA2, and we aren't routinely even testing for it to help people find out about that risk and do something about it. And no matter how you cut it, screening is not prevention. And the screening rates have gone up and up and up, and we haven't made enough of a dent in decreasing the screening rates. And that's really one of the things that I want to focus on. I want to link risk assessment to then direct screening and then prevention or risk reduction. And so that was really the genesis for this. And I thought, well, wow, do we have enough things that we can do? And it's just like anything. If you wait till you have everything perfectly, you've waited too long. So part of it is you have to learn by doing. So how do we develop a platform where people can start to screen and say, what are the things that I do know? What is the most well-validated tool in the United States? That was the Breast Cancer Surveillance Consortium model, is validated across multiple races, ethnicities, million women. So those are the basic things about reproductive factors and exposures and biopsies. Okay, we have that. But the emerging ability to look not just at these very high risk errors in genes that you inherit, but the multiple little errors that you inherit. I mean, the multiple genes that you inherit that really cause variation in your genes. So many, genic risk. Polygenic risk, these polygenic risk, you can create a score and find out, are you in the very top? Are you in the very bottom? Because what if some people have super low risk and don't need to screen? I mean, we sort of do this already in colon cancer and lung cancer. We don't screen people who don't have any polyps, who don't have any signs. That's worked very well. But for some reason, we're very resistant to making any kind of change in the breast cancer world. And I thought, well, why don't we just get started? And let's make this about women, for women, and build in the tools. Once you find someone at risk, you build in the counseling, you build in referrals, try and get people to think about prevention
Beyond the one size
way,
fits all approach.
beyond the one size fits all approach. Think cardiology. When I started practicing, the biggest risk for women was heart disease. That risk of dying of a heart attack, although it was later in life, still was very high. But, there's been this concerted effort to understand people's risk. Those risk tools have been built in, and interventions have been developed based on cholesterol and blood pressure. And we have brought the heart disease rates risk down by 50%. It's now breast cancer is right up there. So your chance of dying of cancer is the same as your chance of dying of heart disease. So I have cardiology envy. I say, why can't we do this for breast cancer? In fact, I'm starting a new meeting called Rise Up for Breast Cancer, where we're really going to focus on why can't we take all the things that why don't we go from this understanding of breast cancer to what are the things that women are already doing with hormone changing, hormonal interventions, cycle control, birth control, in vitro fertilization, postpartum weaning, postmenopausal management. Why aren't we thinking about, well, how can I make all of that risk reducing for breast cancer? What if we too could drop the rates of breast cancer in half? Wouldn't that be amazing? So these are all part of these efforts to try and think differently, think a little bit out of the box, try and make sure that across the disciplines that we really understand what's going on. The risk assessment for heart disease is now routine in primary care. That's not that's not what we do for breast cancer. We could, these tools are widely available. We could say, hey, maybe you're specifically high risk or maybe not. And why aren't we working on improving that? So that's what the wisdom study is all about.
Right.
The end goal is to make this a routine of your primary care. But you're thinking about risk assessment. If you're really at high risk, then let's screen you more. And if you're at risk for a fast growing tumor, maybe screening every year isn't enough. And if you're not at risk for that, and every other year is probably fine. And when you start screening should depend on what your risk is. I mean, these are things that we should really start thinking about. And it's exciting because we have the results of Wisdom 1.0 coming out next year. The MyPEB study in Europe is going to be coming out. This is, and it's not the end. It's not the end. It's the beginning of a new paradigm. It's the beginning of a new way of thinking about things. It's the beginning of how we start learning and keep improving and find ways to really move the needle on breast cancer risk reduction and prevention.
Definitely towards a more personalized approach for each patient.
Definitely. Mm-hmm.
Could you touch a little more on the genetic mutations? One area that we get asked a lot about at Alamo Breast Cancer Foundation is, oh, what about the BRCA mutation? And there's this misconception that's the only one, and if you have it, or this misconception that many people have it, and so there's an increased risk, but there's so much more variety to the genetic mutation factors, right? I mean, it's not just BRCA.
It's not. There are 11 genes that if you have any kind of mutation in these genes, that your risk is elevated. And BRCA1 and BRCA2 are the most well-known. They were the first to be cloned and first to be described. But the incidence of the population is 1%, in the range of 1%, 1 to 2%. A lot of people say, oh, BRCA1 and 2, these are the Jewish genes. No, well, even if it's increased, that risk is 2%.
Right.
So just because it's the more you know about inheritance the more you know about each ethnicity. There are specific mutations in the English population, in the Irish population, in the Bahamian population, in various countries in the Caribbean, and so on, have a range between 2% of the population, 20% of the population of tumors that might harbor a mutation. So I actually think that everybody who has breast cancer should know what their mutation status is, because there are now new drugs coming forward that can reduce the risk of recurrence. These are the PARP inhibitors, and maybe those will be, and we're testing those actually in the I-SPY trial as upfront to see if we can really move these drugs more into the mainstream. Again, it's important to know if you're at risk, but if there are very specific drugs that are pretty well tolerated that make the tumors go away, you may not want to even think about prophylactic mastectomy. That's hopefully in the next 5 years. but everybody should have the opportunity to know what they're at risk for. And even if it's only 2% or another 3 to 5% of patients, shouldn't we know who those people are? Shouldn't we go after the lowest hanging fruit and really try and do our best to manage, screen, reduce risk in the people who have a 60 to 80% chance of getting a cancer in their lifetime? Especially with those inherited mutations, your risk is shifted back a year, a decade or two. And what we want to do is try and make sure we find people, we want to find the people that screening is not today, the young people, right? The people with mutation carriers that have early onset, or the people who have these fast growing cancers that we don't pick up. That's sort of I run another big trial called the I-SPY trial. And it's specifically for, women with big cancers and bad cancers. And, the vast majority of those people are not screen detected because they're either too young or the tumors come up too fast. So this is what I'm saying. This is these are the things that have motivated me to make a difference. Can we do a better job of figuring out, who's at risk and do something to reduce it? Just going out and getting your annual mammogram, okay, that started in the 80s. I think we can do better.
Right, right. Where
Right.
are we in terms of, cost, of course, is a factor in every decision that a patient has to make. And I know one of the apprehensions that many patients have in even entertaining the idea of genetic screening or genetic profiling is the cost of those tests, to determine what sort of mutations they have. Where are we with that? Are we doing better? I mean,
Oh,
have
much
costs
better,
come
much
down?
better. So that's one of the reasons why we thought about this, is because the cost of a genetic test these days is can be lower than a mammogram. There are many providers out there, many companies that do genetic testing, and the costs vary from less than the cost of a mammogram to 10 times more. So you have to be aware. There are very high quality tests. We, in particular, went with a vendor that would do this in a very cost effective way. And so there are companies out there where you could make this very cost effective. I'm not trying to bankrupt the system. And in fact, by screening everybody every year, and especially now with this renewed emphasis on MRIs, that, if we followed the American College of Radiology guidelines, we would be spending $34 billion a year on screening, you know, with a B. Screening is in the 10 to $12 billion range, and a more personalized approach can bring that cost, keep that cost in that 10 to $12 billion range. It's a lot of resource and it's a lot of money, and it reflects the effort and the burden of screening on patients,
Right.
right? So more is not better. More is just more. What we want is more for those that need it and less for those that don't. So this is a way of being personalized and looking, and the only way to make things better is to keep studying it and keep learning. So we invite people to say, you're not going to spend, decades of your life in screening. So you might as well do it with us. So anyone who's interested in being part of this important movement should go to wisdomstudy.org and sign up. You don't have to be, you can be anywhere in the country. You can get your care wherever you want. And but we'll assess your risk. If you're at high risk, we'll personally call you. We'll work on connecting you with a provider who can help you manage your risk. And after we have that initial counseling session with you, and we have lowered the age at which we want to do the testing to 30 because we found we have a little more high risk. About 3% of women, 2 to 3% of women have mutations, but 60% of them did not have family history. So family
Wow.
history is not the best way to assess the presence of these genes if you have a test that does it better and
Right.
that's relatively inexpensive and highly available.
Right.
We've partnered with Color Genomics. That's who's the provider. We know the quality is exceptionally high. We actually now include the 30 genes. So and you can get counseling if you have one of the genes for ovarian or colon cancer risk. This we feel is just important. Knowledge is power. People just need to be informed. You don't want to necessarily find that you're at risk, but if you really are at risk, that's something you can do about it.
Right.
You can
Are
just
there
not
any,
get caught flat-footed.
are there any exclusions, anyone that wouldn't necessarily be eligible to sign up for the trial
If
or
you've
for the
had breast
study?
cancer.
Right.
This is not one of the trials. And then we also have a platform trial for people with DCIS. I think that, in prostate cancer, they've really figured out who in these lower risk, non-life threatening types of tumors, they do active surveillance. And you can do that and half the people wind up not needing any intervention. And for DCIS, we think that's probably true. But I look at DCIS or ductal carcinoma in situ as a window of opportunity for prevention. And just like breast cancer, you can get more than one kind of breast cancer and one kind of DCIS. So certain ones, we have it's really a study. It's called RECAST. The idea is to figure out what the imaging looks like, and it's for hormone receptor positive DCIS. And we're trying out new and better and more tolerable endocrine therapies to reduce the risk of progression of DCIS. These are things that can be hopefully developed and used for breast cancer prevention writ large. So we need better and new tools for that. But there's, we're lucky we have things we can do about it. We just have to get the knowledge and the opportunities to reduce risk in the hands of people who need it.
Where do you think the multi-cancer early detection tests, this emerging area, where does that fit in to all of this, to this profile? Like, how do you feel about those?
Right now, I do not feel that that is a population-based test. Those are 5 to 10 times more expensive than a single genetic test, for one. They would have to be repeated every year. They would probably, if we did this on everybody and we did it every year, every other year, it would be, 50 billion, $70 billion. It's not an affordable thing. And right now, at this juncture, the promise of early detection with these tools is not there. It's not a general population tool. Where I think it could be very useful is for people who are known mutation carriers, or people in that tail of risk, at the very high risk. Maybe there's an opportunity. We have to prove it though. Everyone likes the idea of, oh, there's a magic bullet test, but it's like, and they don't find it early enough. So we're not ready. I think we're studying in the very high risk population, could be an important adjunct. These are things that matter, and we'll learn more about risk. But, that's not, it's not something you want to, when they get it down to $100, we'll talk, right?
Right.
Okay, that's our, $200, because that's, mammograms, $200. And, I think the other thing too is right now, there wouldn't necessarily be a copay. I think you also have to beware if you wind up getting an MRI, sometimes you wind up having to have a copay, which is 20% of the cost of the test, which is a lot. And, you really don't want to be getting these, that kind of a test unless you have risk. If you are at high risk, yes, you should be screening every 6 months, alternating mammograms and MRIs. And why do you not want to just have an MRI? Because it is also an extremely expensive test, and you'll wind up paying a copay, and it has a high false positive rate. I am the queen of MRI. We use it in I-SPY to sort of assess the extent of disease and response to treatment in the right setting. It's an amazing tool, but you don't want to use these amazing tools in the wrong way, because then you can do more harm.
Exactly. So as we sort of go towards the 2.0 phase of the wisdom study, as it evolves, what are our goals now? What are we trying to discover now?
Well, what I'm trying to figure out now is, how do we figure out who's at risk for what type of cancer? I don't just want to know cancer, yes or no. We've already talked about how cancer isn't one disease. So if you've got a slow growing tumor that can take years to develop, you would have a different strategy for screening than if you were at high risk for developing a hormone negative tumor that, can pop up and grow in, 6 months. That makes sense, right? Those shouldn't have the same priority. So what we're trying to do is test the ability of lots of tools, including, again, polygenic risk. The other, you have millions of genes, and We've identified hundreds of these that by themselves don't mean much, but in combination, this polygenic risk score can really identify people at very high risk or low risk. But more importantly, we can start to figure out, well, who's at risk for a slower growing hormone positive tumor? Wow, I've got I could put you on baby tamoxifen for a few years and reduce your risk, and keep an eye on you. Or you are at risk for hormone negative disease, so I could put you on a path of getting more frequent screening using these more sensitive tools like an MRI. And, can we really not only identify people at risk for these different tools, but can we start to, intercede and get people aware so that they are doing those things that they need to do to reduce their risk? From all the things like lifestyle, turns out it's lucky most of the things that reduce breast cancer risk are good for your health anyway. Exercise, low fat diet, more plant-based, there's no, especially, it's very important, really low to moderate alcohol intake. These things are super important, in life. Alcohol is one of the very well-known risk factors for breast cancer. If you like to have more than one drink, pick one night to drink. If you just want a little bit, pick 3 or 4 nights to have a half a glass of wine. Don't, no more than that, really. And you'll find that that's enough, right? And, get yourself a spritzer and an umbrella, make it fun, put some juice in it, right? But those are things that we can do, right, to reduce risk. And if you're a particular high risk, and we know the type of tumor you're at risk for, baby tamoxifen, now this is like a quarter of the dose. 5 milligrams has been shown to be very effective in that prevention setting. So, and now with the DCIS trial, we're testing new things. It'll be hopefully more tolerable. That's how we make progress. That's how we make progress. I want people, I'm tired of watching the breast cancer incidence rates just go up and up and up.
Right.
I want to see that, I want to see that the rates are going to go down.
Right. Exactly. Yeah, and I feel like this is definitely the right way to go about doing this. More personalized approach.
And you know what? It doesn't cost anybody anything. They just have to sign up at wisdomstudy.org. We are funded by the National Cancer Institute. We have a program project to fund this. We're looking at developing mammographic AI and integrating these into the risk tools. We are trying to figure out, have we met our goal of figuring out who's at risk for what kind of cancer? And have we, for the people that are taking up prevention interventions, are we making a difference in the incidence rate? So that's really the goal. I mean, that's the kind of proof I think that we'll need. Wisdom 1.0 was trying to say, is a personalized approach just as safe? The study never got stopped for safety. So we'll have the results to report out next year. Should be very, very exciting.
Very exciting. How many people did we get signed up for it?
So close to 45,000 women. And so we already have 10,000 women and Wisdom 2.0. It's very exciting.
Across the United States, or are we
Across the
thinking
United
about
States. Across the United States. And we finally have achieved our goal of a very diverse population. We have more than 25% of our population in this last 10,000 are African American women. So, and we know this is particularly important because, breast cancer mortality rates are higher in African American women, and we don't understand necessarily why. And it's not just because of triple negative disease, but if we don't have the proper representation or proper participation of women of all races and all ethnicities, then those are groups that will be left behind as we develop these risk tools. Because who you are is part of your genetic makeup. We understand that varies, and so we want to make those tools that assess risk to be very appropriate for and specific to what your own genetic background is.
Wow.
We're lucky in the United States. We have a very diverse population. So, it's very exciting. So, I said this is really, everyone learns a lot about themselves if they join the Wisdom Study, and they also are helping, their families, their loved ones, the whole population of women to learn going forward. So we'll all learn together to keep improving, keep changing the paradigm, till we can really start to move the needle on prevention. And my goal is to drop the breast cancer incidence rate in half.
Awesome. We thank you so much for all of your amazing work in this field. This is great. Very
I, I
excited
would,
to
I
see the
would, I would,
result.
I would just say that, in the I-SPY trials, these are our trials for women at high risk, have high risk breast cancers. We have watched by doing a better and better job of characterizing these tumors and coming up with these better classifiers and figuring out which drugs go with which people. We have taken, or we've really dramatically improved our ability to make these tumors disappear before surgery with new targeted therapies. It's very exciting, and this has been many decades of work. And so I hope that that personalization approach can be brought back, and what we learn there can inform screening, prevention, and that in another decade we'll be in that same place, and the scourge of breast cancer will not be there
Right.
for our daughters and their
Like you
friends.
said, working towards a full paradigm shift in this
Yeah.
field. Yeah. Dr. Esserman, thank you so much for your time. Again, we praise your work in this field. You're a rock star. We cannot wait to see the results. This is so exciting.
Thank you so much, Jonathan. It's a pleasure to be here.
Thank you.
You're welcome.